Good evening, everybody. Can I request that we fill row 3 and 4? Let's not be scattered. If you can do from 1, 2, 3, your row, then we follow. Please. Thank you very much. At the back, my lady with the red hoodie. Hello. Can I have you, row number 3, from bottom here, please? Three. We are left with 4 minutes. Please, let's make it
Okay, good evening everybody, or good afternoon. Welcome to this inaugural lecture of Professor Florence. Could I ask you all just to rise? We're having our procession that's going to be entering the venue. Good evening or late good afternoon, everyone. Will you just remain standing? We are going to sing the national anthem.
Così si geleri Africa, manu pagani su ponolayo, Yizwa imitana so yetu, Gosi si gelera, Tina musabolayo, Murena buluka se chava sa Yesu, ufelice dentro alle mansuegne, si buluke, si chava sa Yesu, si chava sa South Africa, South Africa. Heidi blauw van onze hemel, uit die diepte van ons ziel. Voor ons eeuwige gebergtes, waar die kransen antwoord geeft. Sounds the call to come together, and united we shall stand. Let us live and strive for freedom in South Africa.
Thank you, everybody. You can be seated. So it's always lovely to see a house that's fully packed, and always great to see a lot of academics and students that's soon going to be following in the professor's footsteps to also be present. So I see we've got a number of our rectors. We've got our previous rector, Professor Pretorius here, and we've got our current rector, Professor Balfour here. We'd like to welcome them. And if I might just say that I don't want to steal a line from a previous rector where he says that this is not a funeral, nor an examination. So let's smile. It's a really great event. So thank you, everybody. So good evening once again to our rectors, to the DVC academic, to the deans of the various faculties and colleagues that are here in person and colleagues that are online, and a special good evening to Professor Maria Florence and her family. I was given the honor of being the program director this evening, so I hope that I'm going to do a good job because I know that we are online. So we will start with the program with an official welcome from the Dean of the Faculty of Community and Health Sciences, Professor Padmana Banuni. Let us give her a warm welcome.
Good evening, Vice-Chancellor, Prof. Robert Balfour, DVC Academic, Prof. Khala, and members of the Senior Management Committee. Welcome to our colleagues from the CHS faculty and the broader academic community, our students, distinguished guests, and a very warm welcome to the family of Prof. Maria Florence. I was wondering if her family could stand up for a moment. Could we give them a warm round of applause? Thank you. It is my distinct pleasure to welcome you to the third inaugural lecture of the Faculty of Community and Health Sciences. This evening, we gather to mark an academic milestone and to celebrate an academic career that has lived with purpose, resilience, and an unwavering commitment to community upliftment. We are honored this evening to celebrate the academic journey and public contribution of Professor Maria Florence. She was born into a close-knit Catholic family in Athlone as the sixth of 7 children. Prof. Florence's early life was shaped by love, humility, and quiet determination. Her early influences gave rise to the independence and sense of purpose that have defined her journey ever since. Prof. Florence studied at UWC, and she began her academic career here in 1996. Over the years, she has held pivotal roles, including the chair of the Biomedical Research Ethics Committee, the head of the Department of Psychology, and currently she is the Deputy Dean of Learning and Teaching in the faculty. Professor Florence's body of work reflects a commitment to community-engaged scholarship. Her research addresses one of the most pressing social and public health challenges in South Africa today. That is substance use and its intersection with quality of life, gendered vulnerability, and systemic inequality. Her work is anchored in the lived realities of the communities she engages with, particularly vulnerable populations in the Western Cape, including adolescents, pregnant women, and families affected by substance use. Through her leadership, contextually grounded interventions are being developed in response to the substance use challenges in underdeveloped communities. Contributions that are shaping the field of addiction care and laying the groundwork for improving health outcomes where the need is most urgent. Professor Florence's approach embodies the strategic aspirations of both the faculty and the university as a whole, and that is to pursue research that is socially relevant, ethically sound, and transformative in both intent and effect. This lecture marks a personal milestone in Professor Florence's career. It is also a moment of pride for our faculty. We celebrate a scholar whose work exemplifies academic excellence with social justice at its core, one who reminds us that research must not only explain the world, but also help to change it. Thank you.
Thank you, Prof. Padmana Banuni, for that lovely background. I would like to welcome our rector, Professor Balfour, to give us his views on the purpose of the day. Professor Balfour. Let's give him a warm welcome.
Thank you so much, Prof. Suke. Thank you, Prof. Anita, for the introduction this evening. Good evening, colleagues and guests, and of course, family members and friends who are gathered. It's really lovely to have you all here tonight. An inaugural lecture is such a milestone in the development of every academic's life. It is not only a celebration and an achievement in its own right, but it's also, of course, a culmination of a whole body of work and development. And in celebrating this evening with our colleague, Professor Maria Florence, I want to acknowledge the deans and deputy deans present, members of our executive present, Prof. Monwe and Dr. Nita, and of course, members of the academic and professional staff and students. It's really lovely to have also postgraduate and undergrad students in the audience from the faculty. It's a time for the university not only to recognize one person's achievement in relation to the accolade of becoming a full professor, but also the significance of this as a rite of passage at a university. It's one of the most valued traditions of an institution of higher learning. It's an opportunity to almost, in a way, say, a coming of age, although age is not a requirement for this particular accolade, I must say. But it is, in a sense, a coming of age in the career of an academic. And the tradition goes back to many, many, I think, hundreds, if not over 1,000 years ago, to various Islamic as well as European institutions in which the inaugural was seen as the mark of entry, that up to a point of having achieved this particular status, you were not really part of the academic community in full. And that is why we have below the rank of full professor, associate professors, senior lecturers, and so on. So the professorial status had this historic dimension to it in terms of being a point of entry into the full community of the academic space. And so it is in many ways about a journey that is here and being celebrated this evening in the form of our colleague. And in recognizing and congratulating our colleague on this wonderful achievement, as full professor in the Department of Psychology and Deputy Dean of Learning and Teaching in the Faculty of Community and Health Sciences at UWC, we recognize many forms of leadership in the academy. Leadership can be both, in a sense, managerial, it can be collegial, and it can be academic in terms of how we lead our students, how we lead our colleagues, how we lead ourselves. The title of tonight's lecture, Addiction and Quality of Life in South Africa, Contextual Challenges and Pathways to Recovery, speaks directly, as the Dean noted, to an urgent health and series of social challenges that are facing our country, indeed our communities around us. Addiction profoundly affects the quality of life, and Professor Florence's work reminds us that recovery cannot be measured by clinical outcomes alone. It must include improvements in social inclusion, livelihood, and psychological well-being. Through South African research of this kind, recovery-oriented models, through Professor Florence's work, show us how policy, clinical practice, and community engagement can come together to build equitable, life-enhancing recovery systems. Her lecture challenges us to think differently, to understand addiction not just as a personal or medical issue, but as a social one that requires a social response, a response that is coordinated, that is ethical in terms of its research, and of course that is inclusive in terms of its interventions. I happened to meet Prof. Tyron earlier in the day today, and he mentioned to me that he had been very much part of the development and being present in many ways and over many years in relation to Prof. Florence's work. So thank you, Prof. Tyron, also for that contribution. And then finally, on behalf of the University of the Western Cape, Prof. Florence, I want to congratulate you on your appointment as full professor. We so look forward to the lecture this evening, and perhaps even more than that, the continued impact of your work, both within our institution, but also in the field itself. With those few words of welcome, I want to hand back to our program director this evening and that we can all enjoy the time together. Thank you. Thank you, Professor Balfour. You have really set the scene with regard to the significance and academic importance of the inaugural lecture. Thank you. Ladies and gentlemen, please join me in welcoming Professor Michelle Patent. She is the Deputy Dean of Research of the Faculty of Community and Health Sciences. She will be introducing the inaugural lecture of Professor Florence. Let's give her a warm welcome.
Good evening, everybody. What a privilege and an honor, Maria. It feels like my partner in crime. When I was the HOD of psychology, Maria was the deputy, and when she became the HOD, I became her deputy. Our walk spans many, many decades, and the people here tonight really, really is evidence and testimony to you, Maria, and to the work you've done. To Tyron, Professor Elise Koch, I got such a fright when I saw her. She was so instrumental in our department many, many years ago. And when we speak about Maria, you cannot speak about Maria without speaking about substances. So at some point I used to think, is Maria not on substances? What I also want to do tonight with the family, I know them personally. Maria, I know that Jake's your mom and Nikki smiling down from heaven. Maria lost 3 family members during COVID. And so I know this is a very, very proud moment for her tonight. As I said, her work on substances and quality of life spans many, many years. And I cannot speak about that without also acknowledging Professor Shazli Saval. The two of them have done lots of work together. Many, many years ago, I think when we were just starting to grapple with the issue of substances in our communities, they were talking about substances and quality of life. And so tonight's lecture really should open up our thinking and our minds to understand the gravity of the situation and also recovery pathways, which she basically speaks about in her abstract, and the importance of understanding that we cannot just attribute health to biological, physical kinds of aspects, but that we need to look at the person holistically. And it's not just the user that we know that suffers, but the family and communities. So Maria, the work that you're doing really has a good feel to it. It has the feel of what Bronfyn Brenner speaks about, the ecology of substances, that we cannot just address substance abuse with the individual, but we have to look at all the layers and how everybody is impacted. So ladies and gentlemen, my dear friend and colleague, Maria Florence.
Wow. Good evening, ladies and gentlemen. The leadership of the university, my colleagues from the faculty and beyond, my family, my friends, my students. Thank you, students, for coming. You've lowered the mean age quite a bit in the room today. I greet you with a deep gratitude and a profound sense of humility. I need to start, however, with a small request that you bear with me, since I've just recovered from a flu, and I will, however, do my best to stick to the pace. I may, Delphia, need another one of these, though, if he's in the room. And then I assume, oh, there we go. So it's an honor to stand before you tonight to deliver this inaugural lecture. The journey to professorship was not mine alone. It is tethered to the histories and sacrifices of many. It began in a working-class home in Vanguard Estate in Athlone, where the values of humility and hard work and integrity was seeded early in my life. I grew up in a society structured by the apartheid's exclusions, yet sustained by family, community, and faith. Like the dean said, I was born into a large Catholic family. This is a very small part of my family. I was the 6th of 7 children to parents who did not have the opportunity to earn an education, but were extremely hardworking. They were not able to obtain much formal education at all. Mom worked as a seamstress until my late brother, her 4th and favorite child, that was never a secret, was born, and it made more sense for her at the time to stay home and care for her children instead of paying for daycare. She did this along with caring for a host of other children from the neighborhood. I think part of the reason I liked school when I eventually started was because it always felt like a school at my house, in that there were always so many children around on a daily basis, and Mom kept us busy with preparation for big school. They sent us to a Catholic primary school. This is our school, St. Teresa Primary in Welcome Estate, Athlone, which further reinforced the discipline of learning and working. The nuns, one, Sister Mary Agnes in particular, were very strict. I'll give you an example. It was not until I reached public school in Standard 6, grade 8, that I learned schools have cleaning staff. Because at St. Teresa, we had to clean our own school every weekend. It was just part of the curriculum. I clearly remember Mrs. Dalton, my sub-A, grade 1 teacher, walking me over to this classroom, this very classroom, to show the older children how neatly I could do my letters, even though I had just started school. Mom's early preparation at home was clearly her way of giving me the leg up. High school was at Cathkin Senior Secondary School in Heideveld. That was an adjustment socially, but academically the Catholic school had prepared me well. This was my parents' vision coming through again. Here is where I met and experienced Zubeida Desai. Thank you, Zubeida, for being here this evening. You will know her as Professor Zubeida Desai, the former Dean of the Faculty of Education here at UWC. She inspired us to further our education despite our backgrounds because she was so passionate about learning. She made us believe that we could do it and that we deserved the opportunity. She was a real inspiration to me. Then, in 1988, I was accepted into UCT and UWC for my tertiary education, but my cousin, Reverend Colin Jones, who was the chaplain at UCT at the time, advised me that UWC would be a better fit for me. He also helped to convince my parents to let me study further. I was able to attract a teaching bursary and completed my BA degree in 1990, and it was during my 3rd year that I worked as a research assistant to Professor Tyrant Pretorius, the previous rector of UWC, and the then HOD of the Department of Psychology. He introduced me to the field of research and supervised my honors research project with an NRF grant holder linked bursary, which made studying possible, and then also my master's thesis, which I completed part-time. Thank you, Tyler. In between these qualifications, I completed a postgraduate teaching diploma in order to honor the terms of my bursary. But after the practice teaching, it was clear to me that working in a school environment was not for me. I completed a research internship at the HSRC in Pretoria at a very interesting time in our country's history. In 1993, you see in this picture my first research team at work, Dr. Carmen Ruston, Cynthia Patel and Daxita Mistry, still a team, but in a very different way. I left for Pretoria in the same week that I secretly married my husband, William, whom I met here at UWC when we were both peer facilitators for the first year orientation program. William followed to complete his master's at Wits, but he headed back home to complete his teaching qualification in 1995 and to be present for his son Vincenzo, who was about to start school. I continued to work as a junior researcher at the HSRC and only returned to Cape Town in 1996 after my dad passed away, and I felt I wanted to be closer to the family. I was able to secure a part-time post in the Department of Psychology, again, thanks to Tyron, where I have been ever since. My daughter Lyndall was then born in 2003. So it was not until 2010 when I started my PhD, once she had settled into primary school. My PhD was supervised by Professor Elise Koch. Thank you, Elise, for being here today. And Calvin Mwaba. This is where the dictionary research began. It was Elise Koch who joined the Department of Psychology, I think it was 2007, 2008, who taught us how to streamline what we were doing in order to develop into serious academics. Until then, we were just sort of feeling our way around. A few of my colleagues and I built a research team and decided that we wanted to know why there were so many young people whose lives were ruined by substance use while we were spared the fate, even though we hailed from the very same communities. This is a picture of the team. You see there my Elise Koch. She was my PhD supervisor with Calvin Mwaba. Shazi Saval, he was busy with his PhD at the time. Charles Davids, you will know our latest, or our current HOD in psychology, Serena Isaacs, and Aldron Foten is now at Rhodes. We all then started our PhDs linked to this project. We registered the project in 2008, titled Substance Use in Low Socioeconomic Status Communities in the Cape Metropolitan and West Coast. And we worked to link our PhDs and our students' research to this and follow-up projects. You see some of it there. Then after the PhD, Elise and Calvin retired. Professor Shazi Saval took over, and he did his best to try to keep me on course, creating opportunities for me to advance this research area. I didn't always listen to him. But I will now publicly proclaim, Shazli, you were right. This is my contribution to make. Thereafter, Dr. Tracy Ann Adonis joined the department. She's my respondent today. She joined the psychology department on secondment from the community engagement unit. She taught me how to translate the work I was doing into something that would uplift the communities and what it meant to engage communities to have a lasting impact. Thank you, Tracy. I also want to acknowledge the power of early adversity. My drive is a direct rebuttal to what I didn't have. I recall taking that packed train from Blackheath Station and feeling very unsafe, with everyone pressed up against each other. I walked half an hour to the train station because I couldn't afford the taxi fare, while often silently reassuring myself that I will not need to use public transport forever. That desire for a better future fueled every step. This lecture is not a celebration of achievement, but an affirmation of purpose. As a psychologist, a teacher, and community-engaged scholar, my work has always sought to bridge the gap between knowledge and social justice, between theory and lived realities of our people. Tonight I stand here to reflect on our on that work and to chart what the road ahead could look like in terms of interventions and its impact in society. I am a proud product of the University of the Western Cape. UWC, thank you, Douglas, was not only where I studied, but where I was politicized, mentored, challenged, and ultimately shaped into the academic I am today. From undergraduate studies through to my PhD, UWC has been more than my institutional home. It has been a space of struggle, growth, and belonging. I joined the university as a sessional lecturer nearly 3 decades ago and have remained here learning, building, and serving. So why addiction? Through my research, I've come to understand that substance use is a symptom of an underlying problem. If we treat only the symptom and not the underlying problem, we make the problem so much worse. This is why the recidivism rates are so high for those who do manage to access treatment, which is also a small percentage of those who need it. I want to ask you to hold that as my central message for this talk as I unpack it further. The most recent global data from the United Nations Office on Drugs and Crime and the World Health Organization confirms a growing and evolving substance use crisis. The number of people who use illicit drugs globally is rising, reaching 292 million people worldwide in 2022, a 20% increase over the previous decade. Only about 1 in 11 people with a drug use disorder received treatment globally in 2022, and of those, it was only 1 in 18 women and 1 in 7 men. So for women, it's even more difficult to access the care. Sorry. Alcohol remains one of the world's leading risk factors for disease, contributing to 2.6 million deaths annually, and imposes a particularly heavy burden on young adults. Although global consumption levels have shown a slight decline over the past decade, they remain high, and harmful patterns such as heavy episodic or binge drinking persist in many populations. This data underscores the urgent need for strong public health measures, prevention initiatives, and treatment interventions to reduce the ongoing impact of alcohol use worldwide. In South Africa, the crisis is driven by both alcohol and illicit drug use. Data from the South African Community Epidemiology Network on Drug Use shows that alcohol remains the most frequently reported primary substance of use amongst adults seeking specialist treatment. Their statistics are, however, from those who do manage to access treatment. While we don't have a clear sense of the extent of the problem, I'll try to give you some idea of the challenge with access to care. The estimate of South Africans that have a substance use disorder is between 13 and 15%. In the first half of 2020, records show only 6,000 South Africans access treatment across 82 facilities. A 2024 scoping review estimated that in low and middle income countries such as South Africa, treatment access could be as low as 1%. It's probably not that low in South Africa, but it is much lower than we want it to be. Among the illicit drugs, cannabis, methamphetamine, and heroin drive most admissions, with methamphetamine being particularly dominant in the Western Cape. While this data, based on treatment center statistics, gives us an underrepresentation of the problem, a long-term national survey showed the prevalence of illicit drug use increased dramatically from 1.5% in 2002 to 10% in 2017. These community-based studies, which show a more accurate picture of the problem of substance use, are ever few and far between. Addiction is not new in our country, but given the estimated increased rates of substance use over the last couple of decades, it has taken on new dimensions, deepened by our realities of inequality, gender-based violence, unemployment, and intergenerational trauma, among other things. My academic focus emerged from precisely these realities. As I began my research, I realized addiction could never be understood outside of social context. It was never just about the substance, it was about relationships, environments, trauma, and survival. The core argument I want to make centers on shifting the perspective from viewing substance use as a moral failure to seeing it as a survival strategy driven by underlying mental health needs and societal context. The central argument is that substance use and addiction should be understood not as a personal or moral failing, but as a life jacket, a desperate, albeit unsustainable, solution for individuals dealing with overwhelming feelings, trauma, or mental health challenges. For many, self-medication is a way to numb emotions, avoid intense distress, or cope with conditions like social anxiety, hypersensitivity, intergenerational trauma, or the daily stress of living in poverty. The life jacket, I think, is a useful analogy, because while it serves the purpose of keeping the person afloat, when the dangers of using a crutch such as substances become apparent to the person using it, they often need assistance to get themselves out of the jacket. It's essential to recognize that substance use disorder is fundamentally a mental health issue. Yet, the allocation of resources for mental health support in South Africa remains tragically insufficient. The conventional and frankly outdated argument for the scarcity in the prioritization of resources for ostensibly more life-threatening physical illnesses. However, this distinction is dangerously flawed. We cannot in good conscience argue that mental health issues are not life-threatening when faced with the stark reality of tragedies like the Life Esidimeni disaster in 2016, where the profound systemic neglect of mental health care led to the preventable deaths of over 140 psychiatric patients. Substance use is one of the most immediate and visible ways a severe mental illness can manifest as a life-threatening disease, driving up risks of suicide, accidental overdose, violence, and debilitating comorbid physical ailments. A person struggling with addiction is not merely exhibiting poor choices. They are contending with a chronic relapsing brain disease. It is a direct and often fatal consequence of untreated underlying psychological distress and a lack of accessible, sustainable support. This reality demands a complete reframing of resource allocation within the entire healthcare system. Mental health, including comprehensive care for substance use disorder, must be elevated from an afterthought to a core pillar of public health strategy. Adequate funding is not just a matter of compassion, it is a critical investment in reducing the overwhelming burden of emergency services, correctional facilities, and the economy. Until resources are distributed in a way that truly reflects the life and death stakes of all health conditions, including mental health and substance use disorders, South Africa will continue to suffer these preventable human tragedies. We also recognize the structural and historical roots of the problem. Substance use is prevalent because past and current traumas persist, driven by complex historical and social factors. The effects of historical practices such as the now defunct DOP system in areas like the Western Cape continue to impact current problems. It is critical that we look beyond individual pathology and acknowledge the structural and historical roots of South Africa's substance use epidemic. The high prevalence of addiction isn't a random social ill. It's a direct consequence of persistent past and current traumas driven by complex historical and deeply ingrained social factors. The most stark example of this legacy is the devastating impact of historical practices such as the DOP system, prevalent in agricultural regions like the Western Cape. Under this system, farm workers were systematically paid, in part and in whole, with cheap, low-quality wine. This practice wasn't just exploitative labor, it was a state-sanctioned, intergenerational mechanism that engineered widespread alcohol dependence within entire communities. The effect of this engineered dependency still echoes today, contributing to entrenched cycles of addiction, poverty, and family dysfunction. The sheer scale of the problem underscores the depth of this historical wound. The Western Cape alone is home to a staggering number of wine farms, a figure so vast that visiting one per weekend would take around, guess how long? 9.5 years. This density speaks to a massive regional industry that historically relied on and perpetuated the abuse of a vulnerable labor force. Treating substance use disorder effectively requires interventions that directly address these deeply rooted historical inequalities and continuous societal trauma, not just the immediate psychological symptoms. Oh, this page. The current lack of progress in addiction care is fundamentally driven by stigma and insufficient access to effective treatment. Stigma, labeling, and judgment are primary barriers to recovery. When we judge individuals for using substances as a crutch, we invalidate their suffering and alienate them further. They are left feeling alone in their trauma when they need connection the most. The stigma also prevents family members from openly discussing their pain or accessing family-focused interventions, compounding the trauma for the entire unit. There's absolutely no room for stigma in addiction care. The core need for a person in this state is connection and acceptance. Shaming isolates them, but connection heals. This is especially true in the collectivist cultures represented in the communities within which we worked. Language is an exceptionally important key in the addiction field because it directly shapes how society, health professionals, and the individual in recovery view the condition. Your choice of words can either reinforce harmful stereotypes or create an environment of dignity, hope, and support. Stigmatizing language is a major barrier to seeking and remaining in treatment. When addiction is described using judgmental words, it frames the condition as a moral failing or a personal weakness rather than a chronic, treatable health condition. By using person-first language, such as a person with an opioid use disorder, research shows that health professionals, the legal system, and the public are more likely to prescribe medical treatment rather than punitive action, see the person as less responsible for the illness, and see a better prognosis or hope for the individual. The language used in treatment and by loved ones directly impact a person's self-worth, self-efficacy, and willingness to continue the difficult work of recovery. Stigmatizing labels like junkie or druggie can become internalized as shame, leading to low self-esteem and stress, which are barriers to recovery. Using positive language helps the individual reframe the internal dialogue from self-criticism to self-compassion. Recovery-oriented language focuses on progress, resilience, and growth. Phrases like person in recovery or recovery journey convey that healing is possible and that setbacks are part of the path, not the end of the journey. This language is empowering and fosters an optimistic mindset. When family, friends, and clinicians consistently use respectful language, it creates an atmosphere where the individual feels safe, welcomed, and understood, making them more likely to seek, enter, and remain in life-saving treatment. In essence, language is the foundation for establishing dignity and respect. When we use words that acknowledge addiction as a health issue, we stop defining a person by their diagnosis and instead acknowledge their full humanity and potential for healing. My research has shown that the core question is no longer just, how do we reduce use? But rather, what does a good life look like for those in recovery? And how do we support people to get there? This is why a strengths-based approach with a focus on quality of life, not just abstinence, has become the lens through which we now approach this issue. To help someone move towards recovery, we must validate their journey and help them transition from the unsustainable life jacket to true safety. We must harness that survival instinct, encourage them to redirect that same survival instinct and belief in their capabilities towards dealing with stress rather than avoiding it. We must teach new skills to restore dignity and safety. The goal of recovery is not abstinence alone. It is about helping the person to process emotions instead of numbing them, to empower them to swim safely without the life jacket. We must first focus on restoring a sense of safety and allowing the person to reclaim their dignity, which is essential before they can take off the crutch. In terms of a long-term strategy, the most effective long-term strategy is prevention and systemic reform. Imagine a world where addiction is no longer a dark secret or a moral failing, but a mental health issue, treated with compassion and expertise. The shift starts in the education of our children to address the problem preventatively, as well as through the training of professionals to address the problem curatively in the most effective way. We are failing an entire generation by not giving them the tools they need to navigate a complex world. Our most powerful long-term strategy isn't treatment for those who are already suffering. It's prevention and systemic reform. Imagine a young person facing overwhelming stress or anxiety. Right now, many reach for a substance as their only relief. But what if from primary school onward, their curriculum included mental health literacy? What if they were taught essential practical skills in emotion regulation and managing intense emotional states? We must integrate this foundational knowledge into every child's education. This single act is how we save the next generation. It gives them an inner strength that makes a destructive coping mechanism obsolete. We also need a focus on the people who dedicate themselves to helping. In the past, addiction care was often rooted in judgment or a misunderstanding of the person behind the diagnosis. We need to overhaul the entire field. We know of fairly recent incidents where inhumane acts took place at unregistered treatment centers that were operating illegally. These centers have to be officially registered with the Department of Social Development and the Department of Health so that they have oversight and can monitor closely. The care system itself needs a massive training upgrade. The development of specialized qualifications like the new PG DIP in addiction care currently being developed within our Faculty of Community and Health Sciences. This new training isn't just about qualifications on the wall. It's a commitment to seeing the human being. Our team of academics is working to develop an interdisciplinary, socially responsive course that fundamentally shifts the focus to understanding addiction from the addicted person's perspective. The core principle behind all of this work is simple but transformative. Substance use must be treated unequivocally as a mental health issue. When we stop treating a mental illness as a crime and start training professionals to see it as a treatable condition, we finally close the gap between crisis and true recovery. This is how we begin to heal our communities. In terms of my contribution, over the years, I've led and contributed to numerous studies and that deepened our understanding of addiction and recovery, particularly in marginalized communities. We work to develop context-specific tools. One of my key contributions was the development and validation of the South African Substance Use Contextual Risk Instrument. It is one of the few locally developed tools that takes into account the layered social risks young people face, such as violence, peer pressure, and the normalization of substance use. This instrument has been widely cited, adapted, and used across disciplines and remains a vital contribution to adolescent addiction research in South Africa. Through my work with the International Consortium of Health Outcomes Measurement, I contributed to the development of a standard set for measuring outcomes for patients presenting with addictions for use across the globe. I was the only African partner who contributed to the standard set, which is used across settings for the treatment of all substance and behavioral addiction disorders. Another strand of my work has focused on substance use during pregnancy. Our studies in rural and peri-urban Western Cape reveal that women who use substances during pregnancy often do so in the context of gendered violence, economic precarity, and stigma. In response, we co-designed an intervention grounded in photo voice methodology, a participatory approach that allows women to narrate their experiences and reclaim agency. This work is now published in international volumes and continues to inform local program design. Across these projects, we also explored the idea of recovery capital, the personal, social, and community resources that support long-term recovery. Our findings highlight the importance of connectedness, hope, and purpose, and dignity, factors too often overlooked in mainstream addiction services. I have been fortunate to collaborate with scholars from Belgium, Ireland, Switzerland, the USA, and across Africa. Together, we co-edited and recently published Addiction, Recovery, and Quality of Life, cross-cutting perspectives from around the globe in the Springer Quality of Life series. This volume positions South African and African perspectives at the center of the global addiction discourse, a rare and necessary inversion. My work with the International Consortium for Health Outcomes Measurement, Working Group on Addiction, co-developing a global standard set of patient-centered outcomes now used across continents in addiction services, was another powerful moment of south to north knowledge contribution. As a member of the International Consortium of Universities for Drug Demand Reduction and the International Society for Substance Use Professionals, I engaged in collaborative research to reduce drug demand and develop training programs. Across all these endeavors lies a central philosophy. that addiction cannot be separated from broader questions of quality of life. It is not enough to treat symptoms, we must change systems. A focus on quality of life moves us from managing addiction to enabling flourishing. It means building community connections, strengthening mental health, addressing structural violence, and promoting economic justice. It is in essence about creating the conditions under which people can live meaningful, dignified lives. Scholarship must have impact. For me, that impact is visible in several areas. Teaching and mentorship, some of you are here. Over the last 2 decades, I have trained and supervised over 30 master's and doctoral graduates, most of them from historically marginalized backgrounds, as have my colleagues who worked alongside me. These are the next generation of socially responsive researchers. In terms of curriculum development, along with a team of academics from across the Faculty of Dentistry and the Department of Pharmacy, I currently spearhead the development of a postgraduate diploma in addiction care, the first of its kind at UWC, and we are working with a local community-based organization to develop a continuing education qualification in community mental health for people already working in the surrounding communities, but who have no formal training. In terms of the community engagement, I represent UWC on the board of the Cape Town Drug Counselling Centre and support organizations such as Susapo Foundation, Change Agents, and Olympians Family and Women Support Programs in rural areas. My research has informed real-world programs from interventions for pregnant women to school-based prevention models for adolescents. So what lies ahead? Looking to the future, my vision includes expanding further on the prevention studies, working with children at primary schools. Unfortunately, not all of the work at the primary school level is preventative. We will also be working curatively in some of these schools, deepening interdisciplinary work, working across disciplines, health and social sciences and education, as you've seen in some of the science disciplines as well, to build holistic models of care and training for addiction care professionals. Driving policy change through continued engagement with the Department of Social Development, we aim to influence provincial and national approaches to strength-based treatment, harm reduction, and gender-responsive addiction care, among other things. Building African expertise, we will launch new programs and research hubs that will center African voices, methodologies, and epistemologies in addiction research. We will continue to mentor master's and PhD students, as well as postdoctoral researchers, in order to amplify the impact of our community engagement. I plan to do further exploration of behavioral addictions such as gambling addiction, and a focus on families of persons dealing with addiction. The focus on quality of life moves us from simply managing addiction to enabling flourishing. It is about creating the conditions under which people can live meaningful, dignified lives. To be relevant, a psychology for the future includes social good, justice, healing, and transformation. In conclusion, my lecture today is both retrospective and aspirational. It reflected on a career dedicated to building a psychology that is contextual, critical, and community-rooted. Thank you all for celebrating this milestone with me. My journey to full professorship has been anything but solitary. It has been a profound lesson in the collaborative nature of scholarship and life itself. The success is not just mine. It belongs to a constellation of support that surrounded me. My deepest gratitude goes to God, who definitely has a purpose for my life and my work. I want to take this opportunity to thank my best friend, William. Thank you, William. You've been supporting me in a myriad of ways for over 3 decades, and you continue to do so on a daily basis. I appreciate especially how much humor you always bring to my successes and my failures. My children, who have given me the space to be not just a working mom, but also regularly absent from their lives. My mom and dad, who taught me to walk to the beat of my own drum and instilled in me a commitment to social justice. My larger family, especially my sisters, who aided and abetted when I needed surrogate parents. Having grown up in the circle, I learned early how to harness supportive relationships, how to ensure they remain collaborative and never competitive, which was helpful for my survival and many of my students in the academic environment. My church family for keeping me in their prayers and caring for my family. My friends. I've had the privilege of growing alongside some of them for 20, 30, 40, and even 50 years. My mentors, Zubaida Desai. From whom I learned I could get a tertiary education and build a career. Taryn Pretorius, from whom I learned research psychology and academia was an option. Elise and Calvin Mwaba, who guided me through the steps of becoming a serious academic. Thank you, Elise. Shazi Saval, who kept my focus on my main contribution, and Tracy Anadonis, who helped me shift my focus to address the need. And these, I must tell you, are just the old-timers. There have been many more who have impacted my development along the way. Thank you for the opportunities to grow and for consistently challenging my thinking. Thank you also to all my colleagues in the faculty, the broader university, and across the globe for your support. A special thank you to Tracy, my respondent tonight, for exemplifying the very best of collaborative scholarship. You're not only a close research partner, but a true friend who had my back, understood the insecurities, and pushed me past them. Crucially, you taught me the most important lesson in research, to ensure the work is about the development of the community, not about my publications, and how to facilitate what the communities already knew they needed. I thank the communities who welcomed me and trusted me with their stories, to my research teams, participants and students, research assistants sitting among us, interns, you are the heart of my work. Since registering my first project in the dictionary in 2008, I have been privileged to work across numerous topics and to nurture many of you into the field of research psychology more broadly and addiction research more specifically. My work has taught me that the truest measure of success is not the title achieved, but in the connection maintained and the lives uplifted along the way. Thank you all for being a part of my journey. Even if I didn't mention you tonight, you know who you are, and I hope you know how much I appreciate the role you have played in conducting this body of work and or for supporting me in different ways. I thank UWC for being both the beginning and becoming of my academic life. Let us continue to teach, to research, and to serve, not just for knowledge creation, but for the possibility of a better life for all. Thank you.
Thank you, Professor Florence. What is there to say besides that we are extremely honored to have witnessed your academic life journey, and we wish you well for your future in terms of your academic career. So I want to just spend 30 seconds to share a little story. Prof. Florence probably won't remember this. But I was a student in her class. I'm an occupational therapist, and we are compelled to do psychology in the first and second year. So she taught a course called Research Psychology, and she said that she's an expert in substance use and psychological intervention related to that. Yes, she is. But she's also very well known in terms of research and statistical analysis related to instrument development. So as a first year going in there, I thought, I need help with the psychology, but I'm too shy to actually tell I don't know. You know, those years they used to have MCQ tests, I don't know if you can remember. They still probably have it. And then I went in and I put a lot of, we put little circles next to the A, B, C, D. And then I went into and said, Prof, I really struggled with this. You can see I tried here, but can you just look at it and see whether I'm on the right track? She was very kind, and she rectified all of them, and I thought she's probably going to say I'm a chancer. When I came back, I studied all the correct answers, because she gave me the correct answers afterwards, and we got an A. So Maria, your kindness really helped. It was a little bit of a strategy that I used, but it was very under pressure. But thank you so much. So ladies and gentlemen, please could you join me in welcoming Dr. Tracy Anadonis. She is a senior lecturer in the Department of Psychology, and obviously that's at UWC. Dr. Donis will be providing her insights pertaining to the significance of the inaugural lecture of Professor Florence. Let's welcome her.
Good evening, everyone. Ladies and gentlemen, welcome. I think all the welcomes have been done. The University Executive Director, Prof. Balfour. It is an honor to sit before all of you tonight. And I trust that I've observed all protocol, Yeah. Maria, thank you for those incredible words. You are incredibly generous, my friend. To everyone here, it is an honor to be your respondent on this milestone evening. Maria, hearing you articulate your journey from a promise made on a train platform to this professorship cements what I've always known about you. Your work is not just about what you do, but an extension of who you are. The questions you've implicitly raised in your talk of how and why we work with communities, what we learn, and how we ensure it lasts, are the very questions that have guided our partnership. So, with your permission, I'd like to reflect on them through the lens of the work that we have done together. So, how have we worked with communities? The simple answer is we haven't worked on communities, we have worked with them. We moved from being researchers who extract data to being facilitators who co-create knowledge. In practice, this meant our first step was never to design a methodology. It was to listen. We spent a significant time in community spaces, in church halls, in community centers, not with a recorder, but with a listening ear and a heart of service. Often linking our formal activities to serving a basic meal. So through these engagements, we dismantled the power dynamic of the expert academic and the subject by positioning ourselves as learners. We used participatory methods where community members helped design the research questions, and often when we came with an idea, they would tell us in no uncertain terms, that is not where the need lies. The need lies elsewhere. So community members in our approach, they formed part of the interpretation of the findings, They decided how the results should be shared. So we didn't just collect stories or their stories. We handed the pen back and we facilitated them to write their own narratives and solutions. So why did we work this way? You spoke of a psychology guided by human dignity. This is that philosophy in action. We work this way because the traditional extractive model of research is, at its core, a violation of that dignity. It takes knowledge from a community, packages it for academic prestige, and offers little of tangible value in return. It leaves people feeling used. We therefore chose this collaborative path for two fundamental reasons. The ethical imperative, it is the right thing to do. If our work is truly about uplifting lives, then the process itself must be uplifting, respectful, and empowering. The other reason is epistemological rigor. It produces better, truer science. Communities are the experts on their own lives. When we include them as partners, our research becomes more valid, our insights more profound, and our solutions more sustainable. We are not studying a static subject. We are engaging with a living, knowledgeable system. What have we learned from them? Oh, where to begin? We went in thinking we were there to document a problem like addiction, but communities taught us about resilience, resourcefulness, and redefined what the real problem even was. We learned about the gap between a clinical diagnosis and the human spirit from the mother, the one living in a car. This we encountered in our research, struggling with substance use. A narrow lens would see only pathology, but she taught us about ferocious love. Her entire existence was a negotiation between her addiction and the burning hope she held for a child. She taught us that resilience isn't just about coping. It's about finding a way to dream of a future for your child from the confines of a vehicle. She wasn't just a subject with a problem, she was a lesson in the complexity of love and survival. And then there was a woman who became our community worker. We learned that data is not just collected, it is lived. She didn't just collect surveys, she collected trust. She could see the unspoken trauma in another woman's eyes because she had lived it. She taught us that the most powerful intervention is often not a therapy model, but the presence of someone who can say, I have been there, and I am here with you now. She redefined for us what expertise truly means. These examples taught us the lesson you so rightly highlighted, that our role is to facilitate what they already knew they needed. They didn't need us to arrive with a pre-packaged solution. They needed us to provide the tools, the space, and the platform to unlock the wisdom and agency they already possessed. What we need to do to ensure lasting impact. This is our ongoing challenge. This means not just publishing papers, but helping to secure funding for the community support groups. It means training community members as peer researchers and counselors, creating a legacy of local expertise that remains long after we are gone. Because the funding dries up, right? The project ends and the researchers leave. So to avoid the legacy that ends when the project does, our work must therefore shift from project-based to ecosystem building. We also need to give the data back and transform them into tools that the communities can use. Our final output cannot only be a journal article behind a paywall. It must be a toolkit for schools, a policy brief in plain language for local councillors, a series of community-led workshops. We must return the knowledge in a form that is immediately useful to its creators. And then we also need to practice radical humility in legacy. And what do I mean by that? We must be willing to let go. The ultimate sign of a lasting impact is when the community owns the initiative so completely that they no longer or even remember our names. The work becomes theirs. It becomes woven into the fabric of their community. My dear friend, your journey is a testament to this very philosophy. You didn't just climb a ladder, you built a network, a constellation of support, you called it. And you are now pulling others up with you, as your mentors have done before you. Your inaugural lecture is not an endpoint, but a beacon. So let us take your challenge. Let us continue to teach, to research and serve, and let us ensure our work is always about the development of the community. And in doing so, we will find that it is not just their lives that are uplifted, but our humanity that is restored. Thank you so much.
Dr. Donis, thank you so much for that careful and insightful analysis of that inaugural lecture. It is clear that Professor Florence has made an excellent contribution to the field of substance use and the use of psychological intervention as a strategy. Ladies and gentlemen, I would like to ask the rector, Professor Balfour, to hand over a letter of congratulations and a gift to Professor Florence. I'd like to say, ladies and gentlemen, all good things must come to an end. I would like to call upon Professor Michelle Andy-Payton to do the vote of thanks.
Thank you, Prof. Sukker. Tracy and Maria, what you spoke about now was so important. Our faculty hosted a conference last week at the medical campus at the University of Stellenbosch. And we had community activists, community workers, academics from all sectors. And exactly what you spoke about was what community members were so angry about. The anger was raw, the anger was palpable, because they felt that as researchers, as academics, we're coming to their communities, take the data, publish the papers, leave, and we don't even often acknowledge who they are. So at faculty level, Prof. Sukker, you're the new Dean of Community Outreach and Clinical. We're going to be having these discussions about how we engage. I mean, people were even talking about ethics. Before we go into communities, what kind of ethics do we have? Do we even know what communities need without us coming there to tell them what they are needing? So I think what you spoke about is critical to how we move forward. Then Maria, thank you very much. You spoke about Catholic schools so reverently. I'm a recovering Catholic. They used to bash us at school. So if there's any pathway to recovering from that, I'd gladly take advice from you. So thank you very, very much for your inspiring talk. I think there's a lot that we take away from it. Thank you, Tracy, to the rector, to the registrar, to all the deans, deputy deans, to your family, Maria. Thank you very much for attending. And William, thank you so much for taking care of her. And then to all your colleagues, your students, I'm sure Maria stands as a beacon of inspiration to all of you. So thank you very, very much. To our dean, thank you. for always being there to support us. So colleagues, enjoy the rest of the evening, and yeah, I hope you enjoyed this as much as I did. Thank you.
So ladies and gentlemen, thank you so much for your participation. Thank you to everybody online. We will now stand as the procession will leave the venue. Ask the family to leave next, please. Family of Prof. Florence. The family of Prof. Florence needs to leave, please. Oops. So colleagues, we were asked if you could just remain about 2 to 3 minutes behind. We just want the family to take some photos with Professor Florence, and thereafter we can all leave to the area on top for the catering event. So just give us 2 to 3 more minutes, and then we all can leave after that. Okay, so we got word